I've been a cardiologist for over 30 years in the UK, and I was National Clinical Director for Heart Disease in NHS England. And as part of that role, was involved with developing the NHS long-term plan, which for the first time mentioned heart valve disease as a national priority, which was very welcome. The report launched today looks at the growing health and economic burden of structural heart disease, the key barriers that contribute to suboptimal detection and treatment, and how policymakers at the European and national level should respond. We'll also be hearing from our expert panel of speakers who will be responding to the report's findings. We'll then also want to hear your views in the Q&A session. Before we get started, there are a few housekeeping rules to go through. Internet issues may affect sound and video, so please do bear with us if this occurs. At the bottom of your screen, you'll see a chat function which allows you to communicate with panelists and delegates, and also a Q&A feature where we will be collecting questions for the panelists. If you're having any issues with the audio or video throughout the webinar, try to connect with an Ethernet cable or through a hotspot on your phone. If you get disconnected from the webinar, just use the same link from the confirmation email to join back in. And you're all invited to post comments on Twitter using hashtag structural heart disease and at ILC UK. The webinar is being recorded and will be published for public access on the ILC website and on the YouTube channel. Please submit your questions to our speakers using the Q&A feature in the bottom bar of your screen throughout, and of course join the conversation on Twitter. So with that preamble, it's a pleasure to welcome Aaron Himawan to present the findings of the report. Aaron has been with ILC for about 2 years, mainly leading on ILC's work on global health. She's also worked on topics such as financial advice and generations. And prior to the ILC, Aaron worked in higher education at Goldsmiths College and University of East Anglia's student unions in policy and research roles, working to improve the barriers facing marginalized students. In both roles, she acted as a policy advisor, influencing internal university policy, and produced a number of in-depth pieces of research on program quality assurance, religion and belief, mental health, and consumer law. So with that introduction, Aaron, I'll hand over to you to present the report.
Great, thank you. And welcome everyone. Can I have the next slide, please? All right, so for those of you who are joining us for the first time, ILC is the UK's specialist think tank on the impact of longevity on society and what happens next. As one of the founding members of the ILC Global Alliance, which is an international network on longevity with members across 16 different countries, we also have a very strong global reach. As an organization, we know that increased longevity can actually bring significant benefits to society. However, we recognize that society has to adapt now so that we can all enjoy these benefits. Our program of work and today's launch is about how we can achieve this. Next slide. Structural heart disease is a relatively new term used to describe a set of cardiovascular conditions that affect the structure of the valves, atria, ventricles, and blood vessels in the heart. Valvular heart disease, a term that I'll be referring to throughout my presentation, comprises a large proportion of SHD cases. Though some forms of SHD are congenital and affect young children, the fact is the majority are degenerative, primarily affecting older people. If not diagnosed and treated early enough, SHD can be both debilitating and deadly for patients. That being said, most of SHD can fortunately be treated. Yet, as our report will demonstrate, suboptimal detection and treatment continue to persist, meaning many do not receive care when it's most beneficial to them, resulting in unnecessary health and economic costs to society. Barriers to proper detection and treatment, coupled with the fact that across Europe, societies are aging fast, means that if we do not act quickly, the SHD burden will continue to grow. Next slide, please. So our report will look at the impact of SHD in an aging society by demonstrating that there is a very clear health and economic case for governments to invest in SHD. We will be outlining the barriers that contribute to suboptimal detection and treatment in older adults, and we will also be presenting key recommendations to reduce the SHD health burden. The barriers and recommendations have been informed by a comprehensive literature review, including being reflective of the current policy and political climate. We've also interviewed 5 SHD experts from Italy, Spain, France, and the UK with expert knowledge spanning from healthcare to advocacy. Next slide, please. So as a result of population aging over the last few decades, we've really witnessed a significant increase in the number of people living and dying with or dying from preventable illness. And this is only expected to increase. For example, in 2016, 1 in 5 Europeans aged 65 or over, there was 1 in 5 Europeans that were aged 65 and over. By 2060, it will be 1 in 3. Unfortunately, SHD is one illness that contributes to this growing burden of preventable disease. In 2020, it was estimated that 14 million people in Europe lived with SHD. By 2040, the number of people living with SHD is expected to increase by 43% to 20 million. While these numbers might seem alarming, they are in fact likely an underestimation, as lack of systematic data and on the prevalence and underdiagnosis is a widespread problem. SHD affects the quality of life for people who are living with it. It can severely limit an individual's ability to go about their daily activities, and it can impact their social and emotional well-being. People with severe SHD can experience symptoms such as fatigue and shortness of breath, even at rest, and some may be unable to undertake any physical activity without discomfort. Some may even be bedridden. Recent estimates, however, indicate that every year close to 50,000 Europeans die from VHD. While many people may live for years with mild symptoms without many detrimental effects to their health, if left untreated, mortality increases dramatically. And in fact, you can see in the graph here, severe aortic stenosis, which is a type of VHD, has a worse prognosis than many metastatic cancers. And unfortunately, research indicates that the proportion of deaths due to severe aortic stenosis has recently increased. Next slide, please. Thanks. CVD costs the EU 210 billion euros per year due to health costs, productivity loss, and informal care by caregivers. 50% of that is healthcare spending, and 26% is lost productivity. While the economic impact of structural heart disease across Europe is not yet fully clear, studies have shown that earlier treatment can lead to cost savings. Unlike many other chronic conditions, the symptoms of SHD are acute and can be eliminated with treatment. For this reason, the costs for treating SHD tend to be less than the cost for treating other cardiovascular conditions. Treating SHD can help support the longevity dividend. There is a growing recognition that our increasing longevity can help boost economies, but only if we support people to live well for longer. For example, recent ILC research found that across 27 European countries, older people in better health, so those who have better cognition, are less limited in their daily activities, or report being in good health, are more likely to be in work, they're more likely to volunteer, and they're more likely to spend more. Next slide, please. So our research finds that there are several barriers that continue to prevent detection and treatment of structural heart disease, the first of which is lack of awareness. Our stakeholders said that lack of awareness of structural heart disease and its symptoms on behalf of patients as well as primary care physicians is a key barrier to people receiving life-saving treatment. In 2019, the European Heart Health Survey of people aged 60 and over across 11 European countries found that awareness of valvular heart disease was consistently low across all countries, with the highest level being only 12% in the Netherlands and with the lowest being just 2% in Belgium. The consequence of low awareness means that many often dismiss symptoms as a natural consequence of aging. And moreover, the decline in health due to SHD can be gradual, with people sort of incrementally adapting their behavior and lifestyles to accommodate debilitating symptoms rather than actually going to speak to their physician about it. There have been little to no advertising or awareness campaigns to educate the public as well, and this definitely contributes to this low awareness that we see. Lack of awareness on behalf of primary care physicians, who are often the first step towards a patient receiving diagnosis and treatments, mean that they don't always spot those symptoms. Next slide, please. As mentioned before, early detection is key to reducing the SHD burden. Late diagnosis will increase the likelihood of severe disease and other comorbidities that will make treatment much more risky. Given that awareness among the public is so low, coupled with the fact that moderate and even severe SHD can be asymptomatic, it's important that primary care physicians proactively check groups who are most at risk. The first step in detecting or diagnosing SHD is a stethoscope check of the heart in primary care before referral to secondary care for echocardiography if an abnormality is detected. But what we find is that despite clinical guidelines advising physicians to check their patient's heart regularly, this practice isn't actually widespread, with just only a third of older adults in Europe reporting having their heart checked only occasionally. This number is even lower at 28%, with those reporting having their heart checked at every visit. But what's important to identify here is that there's a lot of differences across Europe. So for example, in France, 76% of those aged 60 or over are checked at every visit, compared with just 5% in the Netherlands. In the UK, we find that 37% of those aged 60 or over have never been checked. In France, this number is only 4%. So our stakeholders also talked about new innovations. They said the digital stethoscope is an innovation that could vastly improve detection and should be widely implemented. They also provide an opportunity for health professionals to be better trained in detecting SHD, and they can also offer more reliable patient assessments. Next slide, please. Ageism is an underlying barrier to suboptimal as well as referral and treatment. And its detrimental impact can really mean the difference between a patient living or dying. We've already seen a glimpse of ageism at work. SHD symptoms are often dismissed as a consequence of old age, so patients do not seek treatment. But this also holds true for medical professionals, meaning they may not investigate SHD symptoms. But there are other ways in which ageism creeps in. For example, younger people are more likely to receive proper cardiological investigations, from echocardiography to measuring cholesterol levels. There's also an issue of undertreatment, where medical professionals do not always use the right equipment to assess older adults, leading them to overestimate the risk of treatment while failing to fully take into account the potential benefits to the patient. Indeed, data collected from patients with severe aortic stenosis across 9 European countries between 2015 and 2017 found that symptomatic patients were being referred for further treatment late in the course of their disease. Our stakeholders also expressed further concern that too many older people with SHD are being placed on palliative or end-of-life care pathways rather than being referred on for treatment. But one stakeholder stated that with the advent of less invasive and less risky treatment, even those aged 90 or over could undergo successful life-improving treatment. Our stakeholders were also concerned that there may be a reluctance among some primary care physicians to refer patients on for further diagnostic tests, and that ageist attitudes, such as a belief that nothing can be done to help them, are a contributing factor here. Next slide, please. Despite there being sort of a range of treatments, including minimally invasive procedures that require less recovery time for the patient, a significant proportion of people with SHD are left untreated. Different European countries also show variation in the choice of treatments available. In the UK, a report by Heart Valve Voice suggests that 30% of people with VHD are left untreated. In France, a review of patients with tricuspid regurgitation, another type of VHD, found that only 10% received a tricuspid valve intervention. Our stakeholders were concerned that patients, and particularly older adults, were not always receiving the best treatment options, and that this should be carried out by a heart team who would be best placed to account for the patient's preferences. One commented that the guidelines as well underpinning structural heart disease treatment had also been built around younger people, and that it really should be taking into account the needs of older people. They also pointed out that it would be increasingly useful to have input from geriatricians in care and treatment decisions, and for cardiac surgeons and cardiologists to make use of assessment tools such as the gait speed test, which tests speed taken to walk a defined distance to determine the fitness for surgery rather than simply basing it on an individual's age. Access to treatment also varies within some European countries. For example, one study showed variation across England in access to transcatheter procedures, such as the transcatheter aortic valve replacement, which is a new but common treatment intervention for SHD that can actually significantly boost survival rates and quality of life. Our stakeholders also expressed concern that hospital capacity may affect the ability to treat patients, and that suboptimal funding prevented some countries from using minimally invasive procedures. Next slide, please. So there are some steps that can be taken to ensure high quality of treatment for everyone. Treatment at specialist centers by well-trained staff, rolling out specific care pathways, which do not yet exist for SHD, all have a part to play in the delivery of high quality treatment. Guidelines for clinical practice are a useful tool to share evidence and standardize good practice among clinicians and across borders. And they can also help to ensure all patients receive high quality treatment and care. They should be regularly updated to capture newest developments in the management of SHD, and even more importantly, adopted in all European countries. We also need better training to support the growth of specialist SHD treatment procedures, increasing specialization such as roles that sit between surgery and cardiology also has implications for the workforce. Therefore, we also need to ensure sufficient workforce capacity in the future and standardization of this new emerging specialism. Next slide, please. As mentioned previously, we continue to underestimate the prevalence of structural heart disease across Europe, and we would benefit from having more routine data collection processes in place. We also miss harmonized registries that could give us a better understanding of how SHD affects different communities and will be able to help us illuminate any inequalities in treatment or outcome. France currently runs a registry of SHD patients, and other countries should follow suit. There are also economic benefits to detecting, diagnosing, and treating SHD earlier, but our stakeholders express that much more needs to be done to fully demonstrate these cost benefits to politicians. For example, we know that less invasive methods of treatment are not only preferred by patients, but are also less costly to healthcare systems. So ensuring that this message is clearly communicated to politicians and policy makers is crucial. Next slide, please. SHD and CVD have received little attention from policymakers across Europe. European policymakers acknowledge that action should be taken to address the disease. However, a streamlined policy approach and action at the EU or national level is still largely missing. And what we often find is that it's tacked onto overall health strategies, which means that it's not given the proper attention that it needs. That said, there are some countries that are leading the way and have dedicated specific policy attention to cardiovascular disease, and a few of those also include SHD as a priority. This includes Spain's new CVD strategy to be launched this year, which will include SHD in there, UK's NHS 10-year plan, which highlights the importance of better support from heart teams for SHD patients specifically, as well as the Scottish Government's heart disease plan, which recognizes valvular heart disease as one of its key long-term priorities. The need for action, of course, is quite clear already. However, this, particularly when coupled with the impact of COVID-19, we can really see that the case for investing in SHD is really, really clear. Older adults have been reluctant to visit their primary care physicians or go out to see specialist services, and patients with cardiovascular symptoms have also been reluctant to call an ambulance or go to hospital during the pandemic. This is particularly worrying as data suggests that patients with SHD might be particularly at risk of from dying from COVID. Our stakeholders were very concerned about the long-term consequences of missing patients. They said that more people will die from SHD as a consequence of not being diagnosed at all or being diagnosed too late. One was even aware of a patient who had chosen not to undergo a treatment for SHD due to the risk of COVID-19 and had died as a consequence. Other problems such as backlog in demand and influx in patients coming forward once the pandemic ends would also cause pressure on diagnostic and cardiac services. But what we can see with COVID is that it's also forced a reshaping of the way healthcare systems deliver services, and this shift has been very noticeable in SHD as well. There's been a shift towards using less invasive treatments, and of course, remote patient monitoring to keep people with SHD healthy and out of hospital, and also reducing the burden on hospitals and the broader care systems. Next slide, please. So the good news is that there are clear ways forward to address the barriers that we've outlined in our report. And these fall into sort of three broad categories. The first is increasing awareness and improving detection and treatment, inspiring and engaging policymakers, healthcare professionals, and individuals, and more effective technology and data gathering. So we must improve SHD awareness among the general public. It's imperative that we make people aware of the symptoms so that they seek treatment. Policymakers should invest in public awareness campaigns to educate the general population about SHD and its associated symptoms. Primary care physicians as well must be better educated on structural heart disease. Equipping primary care physicians with the necessary training is crucial, including the knowledge to regularly check the hearts of older patients. We need to be investing in early detection. This must be central to tackling the SHD burden. People aged 65 and over should have the right to an annual checkup, which should include an SHD consultation and a stethoscope check. The EU and national governments should make funding available to establish early detection programs as well. Clinical guidelines on SHD diagnosis and treatment must be adapted and updated. They should capture the newest developments in the management of SHD. They must be clear on where and when to diagnose and treat SHD and adopted by European healthcare systems as the gold standard of care. We must also create clear care pathways. Healthcare planners must establish specialist centers with appropriate trained multidisciplinary teams and to ensure that all SHD patients are treated at them. Next slide, please. So we must also build stronger cross-country collaboration and a multi-stakeholder approach to ensure best practices shared with a strong commitment to reducing the burden of SHD. Such an approach can actually help to open avenues to funding more research and development, data gathering, hospital planning, as well as awareness raising. We call for a European joint action or the development of a European reference network on SHD. We need a strong political commitment as well and backing from national politicians and policymakers. This can, in fact, create a domino effect leading to greater awareness and clearer care pathways. We must also demonstrate to politicians and commissioners the cost benefits of detecting, diagnosing, and treating SHD earlier, including informing on the cost-effective procedures. At the national level, every country should implement a CVD strategy, which includes a comprehensive approach to tackling SHD. Addressing ageism is crucial as well. It must addressing the impact it has on diagnosis, referral, and treatment has to be the center of any policy response. We must ensure that it's not only core to SHD policy response, but also the wider aging policy response. We begin by calling for greater attention to the impact of ageism in follow-up health initiatives to the EU Green Paper on aging. So patients of all ages should be empowered and encouraged to come forward for diagnosis and appropriate treatment. Age should not be a barrier to treatment. Each patient should be involved in the discussions about what they want from treatment and what procedures would best meet their individual needs. And clinicians should be taking these wishes into consideration. Patient groups should also play a key role in raising awareness, highlighting concerns, and pushing SHD up the political agenda. Ensuring patient voice is heard in health and social care planning decisions means that the priorities and services will better meet each of the community's needs. And we must also address workforce capacity, and we must plan for the future and ensure healthcare professionals get the necessary training to carry out specialist procedures. Next slide. So, each European country should collect a robust, standardized SHD data to be shared across Europe for a better understanding of how SHD affects different communities and what inequalities exist in treatment or an outcome. Medical societies and other key stakeholders should advise on the data that clinicians and healthcare systems should be regularly collecting about their SHD patients. It's also very important that we establish a European registry of SHD patients to start. Clinicians and healthcare systems must take advantage of innovations in detection, diagnosis, and treatment. New treatment approaches are likely to lead to fewer associated complications than the traditional surgery will continue to be developed. Artificial intelligence with potentially provide further ways to improve SHD detection and diagnosis. Health planners and policymakers should encourage the uptake of innovative new diagnostic tools and treatment methods that have the potential to improve outcomes for people with SHD. Finally, the EU as a whole, as well as individual countries, must continue to invest in structural heart disease research to improve treatment and outcomes for people with SHD. The last decade has already seen major innovations in the space. The development of prosthetic, mechanical, or biological valves has also continued to evolve and improve. And such research and innovation can only occur with investment in research. Before I close, it is also worth mentioning that there is already emerging political willingness and commitment to investing in structural disease. There's the EU SHD Coalition, which was launched this year, and it aims to bring together key opinion leaders, politicians, and patients to work together and ensure that policy on SHD is prioritized. The EU for Health program, which was entered into force March of this year, will inject funding worth of 1.5 billion euros into the EU countries, health organizations, as well as NGOs. And 20% of that funding is earmarked for programs that support health promotion and disease prevention. And finally, the Next Generation Recovery EU is a recovery plan that will inject 750 billion euros into member states to boost economic recovery following the pandemic. A significant proportion of these funds will be devoted to healthcare and digital transformation. So we believe actually these three mechanisms represent a crucial opportunity for us to actually move from our recommendations that we've identified here towards action. Thank you very much. I will hand over now to Professor Huon.
Thank you very much, Sharon. A great presentation. And I would certainly encourage anyone who hasn't read it to read the report. It highlights the barriers, which I think many who've worked in the field of heart valve disease recognize very well, and the recommendations, albeit challenging to implement, would certainly go a long way towards improving things. So at this stage, we move on to reflections of our especially expert panelists. And the first I'll introduce is Baroness Judith Jolly, who's a member of the UK House of Lords and was appointed at the Lords Whip and at the Department of Health, the Ministry of Defence, and at the Department of Culture, Media and Sport in October 2013. She joined the Liberal Party in 1984, and appointments in the past have included being chair of Devon and Cornwall Regional Executive, appointed as co-chair of the Liberal Democratic Parliamentary Committee on Health and Social Care. But the majority of her professional life was spent in the far southwest of England, where she taught mathematics for over 15 years and then became a pioneer of IT in schools. Whilst in Oman for 3 years, she worked in the British Council teaching English as a foreign language and mentoring NVQ management students. In 1997, she was appointed as a non-executive director for an NHS Trust for Mental Health and Learning Disability, and then an NHS Primary Care Trust, finally chairing the North and East Cornwall NHS Primary Care Trust Board. She was a lay inspector for the Commission for Health Improvement, so much of a track record in healthcare. Baroness Jolly, would you like to give us your reflections on the report?
Yeah, thank you very much for that. Good morning, everybody, and thank you, Aaron, for presenting the report. As has been said, I'm a politician, a member of the upper house, the House of Lords, and have been for over 10 years. And I have a particular interest in ageing and older people, and have spoken on health issues for well over 20 years in various different arenas. I think this is an interesting debate, and I'd like to also take the opportunity to thank Edwards Life Sciences for their support today. So what is a structural heart defect? Structural heart disease, a set of cardiovascular conditions that affect the structure of the heart. If left untreated, SHD can shorten life expectancy and severely impact on an individual's quality of life. Now, in Europe, around 14 million people live with structural heart disease, and I was trying to find something that I could, an area that actually had around 14 million people, and the population of Calcutta is around 14 million. So that's quite an interesting thing, that the population of Calcutta has, or the number of 14 million people who live in Calcutta have HSD in Europe. And alarmingly, in 20 years' time, the figure is expected to have increased by 50% in Europe, rising to around 20 million. And perhaps we should treat these figures with a pinch of salt. Aaron has suggested that the figure doesn't accurately reflect the reality. Now, many don't see their physician regularly. In some countries, cost is often an issue. And I think British politicians can very, very often fall into the trap. It's really very easy for us. We can pick up the phone, make an appointment to see a GP. It doesn't cost us anything. In much of the world, treatment costs. But many don't realize they have a condition and put it down to old age and inevitability. And this is really common. I saw it with my parents. We don't want to bother the doctor. They've spent most of their life being under the umbrella of the NHS, and they still have this mindset that they don't want to bother the doctor. Fewer than 1 in 8 people in Europe are aware of SHD. Only 1 in 3 Europeans aged 60 and above say their primary care physician checks their heart with a stethoscope occasionally. I have just lost my screen. No, gosh, sorry about that. Only 1 in 3 Europeans aged 60 and above say their primary care physician checks their heart with a stethoscope occasionally, one of the main ways to detect SHD. I've just joined a new GP practice, and it will be really interesting when I have my first appointment, quite what sort of overhaul I will get. But I do fall into the age group where I should be checked. But we do need targeted awareness campaigns. Older people need to visit their physician and so improve detection rates. We need better educated physicians to ensure, we need to ensure that structural heart defect awareness is part of their continual professional development. But also, ladies and gentlemen, this is a political issue. Politics is about people and about their well-being. Politicians, city leaders, town leaders, local mayors and parliamentarians in national and European parliaments have a responsibility for structural heart defects. So what should this look like? For people over 65, they should be having yearly checkups with a physician. Clinicians are generally looking for arthritis, osteoporosis, COPD, joint pain, vascular disease, dementia, and atrial fibrillation. It should include heart health. Structural health defects should be part of the list of things that are looked at. But once diagnosed, there must be clear care pathways for patients and clinicians. Structural heart defects are easy and relatively inexpensive to treat with a simple procedure, which can often be done without a general anaesthetic. But the patient voice should be heard through all of this. There should be universal awareness. And how can we do this? We need to involve older people's groups. We need to involve patient groups. We need to involve civil society. But we must involve more than those who might be defined as middle class, people like me who have sharp elbows and can navigate the system. And in the UK, we have the NHS long-term plan, which was a really, really long overdue document and made really interesting reading. If you look on a global level, in the UN, there's a right to age healthily. We have a right to age healthily, but where is that plan for aging? So everybody here, everybody represented here today has the right to attend the the UN. The WHO states a longer life brings with it opportunities, not only for older people and their families, but also for societies as a whole. But it then goes on to say that there is little evidence to suggest that most older people today are experiencing their later years in better health than their parents. And I think as policymakers, like me, but as clinicians like many of you are, that really should bring us up short. We should do better than that. And we can't use COVID-19 as an excuse not to put these sorts of improvements in place. But the good news is that treatments for structural heart disease are improving, whilst in some cases, open heart surgery may still be the best solution. But minimally invasive catheter-based therapies have made care easier on patients with fewer complications and quicker recoveries. I sit on a group in Parliament, and there is an MP who had to have open heart surgery in order to sort out his heart valves. And within 6 months, the treatment he had been completely outdated, and all he was left to show for that, apart from a new valve in his heart, was a thumping big scar on his chest. But you need to check your local plans, and if there isn't one, you need to make one. You won't need to reinvent the wheel. Many organisations have made plans, and you can readjust them for your local circumstances. We can do better, but to you all, I say thank you for listening, and please take the opportunity and take responsibility. Ladies and gentlemen, there is no time for delay, and in 10 years' time, I'd be really sorry if we were still having these same conversations.
Thank you very much, Baroness Jolly. Very useful summary, and I can see from the Q&A section that a number of the questions might be ending up being directed towards you. So what parliamentarians can do to help us improve things. So we'll come back to that. Our second expert panelist is Professor Paolo Mani, who is Professor of Pathology at the Università degli Studi di Milano. Professor Magni received a degree in medicine and postdoctoral degree in endocrinology in Pavia, and a PhD in endocrinology and metabolism in Milan. He spent a 3-year fellowship at the University of Texas Medical Center in Dallas, and is currently Professor of Pathology in Milan. He's involved in both experimental and clinical research, and his research domains include the molecular pathophysiology of cardiometabolic diseases and the nutritional and nutraceutical modulation of cardiometabolic risk, aging, and health-related issues. He's the co-author or author on over 110 scientific papers in peer-reviewed international journals. So Paolo, would you like to give us your reflections on the report?
Yes, thank you very much, Professor Gray. And I wish to thank you and thank the ILC UK for this invitation. And it's a very nice opportunity to discuss this very important point. The critical issues about SHDs. So all of us recognize that this is an important, rather neglected social, health, economical issue. And like for many chronic diseases, and we need to, with a stronger social impact and health impact and economical impact, we need to involve all the stakeholders. So basically, I'm not only a researcher and a physician, but also I work at the Italian Health Foundation in order to be advocate for patients, for the citizen. And this is important because, I mean, it's a very old kind of expression, but altogether we can win, or we can improve at least the situation. This is quite difficult sometimes, but I have a privilege nowadays to be part of the steering committee of the EU SHD coalition, which was started in the last March 2021. And this is a very important activity on a European base to promote activities starting from, for example, documents and increase the awareness of all the stakeholders, from politicians to the citizen through the health professionals and so on. The health professionals are actually close to me since I am one. And I always think that, I mean, I always, you know, have in my mind the so-called motto, early, 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 which means early identification, early clinical suspect, even before any clinical sign and symptom. Of course, it's just a matter of putting a stethoscope on the heart and possibly listening to what happens, maybe a heart murmur. It's quite obvious what I'm saying, but you know, several colleagues don't even visit anymore patients. I'm talking about sometimes, you know, GPs, general practitioners, who are very much busy and involved in paperwork. So we need to go back to, as a physician, to the basics of our work, which is also listening to the heart, auscultating the heart. This can be a starting point. Apparently very simple. This can be done by other health professionals like nurses, just to identify an initial maybe problem, for example, in the flow through the valves. Early and correct diagnosis is the second early quote. And early diagnosis is important in every disease, especially chronic diseases. So this is an important point. The threshold of 65 for having a yearly visit is important. I can see it even as a starting point, because auscultation of the heart, or at least listening to a person, to a citizen, is important by not only physicians, but also occasionally by, let's say, pharmacists, when you go to the pharmacist or to other places where there is a healthcare professional that can really understand a little bit what it might going on. The third early is appropriate treatment. As Baroness Jolie said, we actually have now important progresses. So it's not just a major surgery or a devastating situation. In many cases, we can solve problems in a rather simple way due to the technological advancement. So this is important. We don't be scared about, as citizens, scared about undergoing a surgery which is not so invasive like it was in the past. And this is another very important point. I think it is important also the occasional identification. So just to close my initial conversation, I wish to tell you a very little but important story. We have in Milan we are conducting since 20 years an epidemiological study, over 30,000 people living in the surroundings of our hospital. So every 5 years, each of them come to our center, and they have a full visit. They have several diagnostic procedures, body composition, full biochemistry. You are collecting also samples from the gut microbiota, which is very much fashionable. It's very important as well. And we do this heart auscultation. So I came across a retired teacher. He was 70 years old at that time. And I found a heart murmur and said, well, do you know that you have this type of, well, no, I don't know. Nobody here is the age of 70. And so, and then I proposed to enter into a diagnostic process protocol just to see what was appropriate. He got, after a few months of diagnostic protocol, he got a valve, aortic valve substitution with a prosthesis. And every year, I'm very glad about that. And every year, at the holiday season, it comes showing how grateful he is. And so this is a very nice story, it's a little story, but occasional identification is also important. So I can conclude here, then we can discuss a little bit more and answer to the questions later on. Thank you very much.
Sorry, I was on mute for a moment. Thank you very much, Paolo. Again, there are one or two questions in the Q&A that will be directed to you, so I'll come back to you shortly. Our next expert panelist is Sylvia Perel Levin, who is chair of the NGO Committee on Aging at the UN in Geneva and representative to the UN of the International Network for the Prevention of Elder Abuse and the International Longevity Center Global Alliance. An advocate for the rights of older persons and an independent consultant, she has been working in the fields of health, aging, and human rights for over 20 years. Before that, she was a theatre and TV producer using the arts to promote social change. She was born in Argentina and has lived, studied, and worked in England, Israel, Hungary, and Switzerland. She has a BA in Social and Educational Theatre from Tel Aviv University and an MSc in Interprofessional Practice from the Institute of Health Sciences of City University of London. So Sylvia, welcome to the panel, and perhaps you'd like to give us your reflections on the report.
Thank you so much, and thank you, ISU. Okay, thank you, Aaron, for a great presentation. And I will not pretend that I know a lot SHD or cardiovascular diseases. So my approach or my reflections are around ageism and human rights. In the report, and you very well noted that ageism and combating ageism has to be at the center of all policies tackling the lack of access or adequate care to of SHD. I would like to claim that ageism is not just one barrier. Ageism is also at the root cause of all the other barriers too. So that we cannot look at any access to care of any condition of older persons without looking in the wider context of ageism and human rights. According to the European Agency for Fundamental Rights, FRIA, age-based discrimination is the most widespread form of discrimination across the EU. And yet it is not considered as equally severe and important as other forms. And we actually know that ageism and age-based discrimination is the really most prevalent of all forms of discrimination. And it is tolerated, accepted, and even is legal in many cases. I would even say in most cases, there are many instances of policies that are ageist, so that encourage the society to be ageist. However, the UN Global Report on Ageism that you also mentioned in your report, that was published in last March, described all the detrimental effects of ageism, and including cost, and including the fact that it is an issue of life and death, that ageism causes morbidity and mortality. But also mentions that there are 3 types of interventions that can work to prevent and to combat ageism. They are the strategies and the pillars of combating ageism are policy and law, educational activities, and intergenerational contact interventions. All these 3 strategies are relevant to what we are talking about today. Policy and law, strengthening policies and laws against ageism can be achieved by adopting new instruments at the local, national, or international level. And if parliamentarians are looking forward to find ways how to help here, I think that looking into ageism and looking into forbidding age-based discrimination is the first step to take. But for that, you also need to have the structures in place that to monitor these instruments, and as I said, may take out of law to make illegal the policies that at the moment are ageist. So we do need the monitoring bodies and the national and the international levels to ensure that effective implementation of the policies and laws that address discrimination, inequality, and human rights, following the fundamental principles of equality, non-discrimination, participation, the autonomy of and independence of the older person. That's why I also claim and I advocate for the UN Convention on the Rights of Older Persons that can assist governments to respect, protect, and fulfill our rights. Because the government has these responsibilities to protect, to respect, first of all, our rights. That means that the government itself cannot violate our rights. Protect, they have the responsibility to prevent others to violate our rights, and to fulfill our rights to actively prevent the violation of rights. This convention could raise awareness of all sectors of societies and all generations that we all have the same rights and that we should all age free of discrimination. Right. Because we do need a legal foundation to end the systemic ageism that we experience and we witness so strongly during the COVID-19. And if I have time, I come back on that a bit more. But you also mentioned today as well the Green Paper by the EU. And I would say that unfortunately, the paper frames the debate solely on aging in terms of economic and social impacts related to the demographic changes, constrains that focus constrains the debate to a narrative of financial and economic sustainability that perpetuates the attitude towards older age as a period of decreased productivity and capacity, and emphasizing the dependency on others. The Green Paper fails to expressly recognize the equal enjoyment of rights and the prohibition of discrimination based on age. We should also stop using the phrase old age dependency ratio. I think it's mentioned there somewhere. This again strengthens the perception that simply because you are old, you are dependent. And dependency is not dependent on age. It can depend, one can be dependent at any age. So that we need to strike, because the way that we gather data and the way that we reflect and analyze the data, it also reflects on the way we are ageist or not. So this is also something that I think that also the Green Paper refers to, and we need to strike out of our language. So Age Platform Europe and the joint contribution from the independent expert on the rights of older persons, the special rapporteur on disabilities, and the special rapporteur on the right to health called on the EU to adopt, first of all, a white paper and to adopt an equality strategy for the rights of older persons that would provide the conceptual framework for age-inclusive mainstreaming in line with the human rights standards and principles. So this European age equality strategy can address age discrimination, can assess the impact of EU policies and actions on all age groups, and suggest and coordinate the policy options for the equal participation and well-being of all generations. So we need to address the ageism at the root, and without addressing the pervasive ageism and the lack of equality that can act as a barrier to diagnosis, referral, or treatment, as you well said, we cannot reduce SHD morbidity or mortality. So this should be the basis for future action. Human rights obligations and commitments undertaken by the European Union and its member states and beyond the European Union, I would say around the world, must form the backbone for all reflections and policy decisions on aging. And when we talk about access to care, we also need to understand that access to care is not just, not all older persons have access to a GP or access to primary health care. There are many people also in Europe that are not living in big cities, that they do not have access to medical doctors on a regular basis. So that we need to think about other ways, not just in our recommendations to go and see the doctor, but also how can we make sure that doctors come to rural areas to make sure that they can see those who do not have normal access to even primary health care. So, but what I'm saying that while we don't have now an international framework, there are enough policy frameworks or human rights frameworks in Europe that also the governments should attain to when talking about older persons, and not assume that simply because we are old, we are going to die anyway, so doesn't matter, why should we diagnose a disease when we are dying anyway? And this is what happened during COVID-19. We saw ageism and age discrimination amplified in so many ways, just in the way that media and public service announcements portrayed older persons, in the social media, in the discriminatory practices enforcing the confinement on older persons more than on others. forcing isolation inside the rooms, not just inside the institutions, but inside the rooms of an institution, and having age-based triage, or not even accepting people. You mentioned not calling ambulance. Some ambulances were told, don't bring older persons to hospitals for any reason. So people were really neglected and denied the basic right of accessing basic care. So I was, and something that is also missing, and that was missing, of course, during COVID, but is missing in the narrative in general, is the absence of the voices of older persons. So you did mention, and I think all the speakers mentioned, the importance of patient groups, the importance of listening to the person, not just to use the stethoscope, of course to use the stethoscope, but also, as I think Professor Magni said, listen to the person. We need to take into account, because also when somebody has a structural heart disease, may also have other conditions, but this person may also be depressed and may not even know that that maybe the depression is a result of a physical condition, or the other way, or vice versa in many cases. So the issue is listen, that we cannot take even policies or recommendations without consulting with those persons who are that we are talking about. And we older people want to be listened to, and we have the right to choose the treatment or to refuse treatment. But in order to choose the treatment, access the treatment, or refuse the treatment, I really need access to appropriate, adequate information in a way that I can understand it. And many of the problems is that sometimes the information comes in such a way that it looks for professionals and not for us. And I think that public information, public awareness, along with professional awareness is here crucial. And we talked about education, and education, it involves education across the life course and all levels of education, including primary healthcare workers, including nurses, including geriatricians, and including continuing education that is lacking in most parts of the world. In fact, in most parts of the world, there is no geriatric studies included in medicine studies. So there is a lot that we have to do. And I think that Europe has a responsibility not only to improve the care of their own citizens, but also have a responsibility to improve the care of those who cannot afford the basic care around the world, and could play a leading role in monitoring and in mentoring professionals around the world. And I think that, again, with that message that ageism, age-based discrimination should not be tolerated, I think I will leave it there, and I will be happy to come back and answer questions. Thank you.
Thank you very much, Sylvia. You make some very powerful points about ageism, and it's something that as specialists who focus more on the sort of the valve disease or the structural heart disease, we perhaps don't pay enough attention to the age-based discrimination that that is around us. And I'm sure we'll come back to you with some questions from the Q&A. So our fourth expert panelist is Ken Bluestone, Head of Policy and Influencing at Age International, which works to improve the well-being of older people in lower and middle-income countries. He has been a passionate advocate for the rights of older people for the past 12 years and has campaigned to see greater attention paid to the health rights and needs of older people, particularly in relation to non-communicable diseases. More recently, he has co-authored If Not Now, When?, a research report identifying the limitations of humanitarian responses to meet the needs of older people. He has worked with a wide range of NGOs throughout his career on various issues, including aging and development, humanitarian response, human rights, water and sanitation, HIV and AIDS, corporate social responsibility in the pharmaceutical sector, and food sovereignty. Ken is on the board of directors of Common Age, a Commonwealth Accreditors Association, and was previously chair of the Global Alliance for the Rights of Older People. So Ken, perhaps you'd like to give us your reflections on the report.
Thanks so much, Yun, and thanks much very much to ILC UK for allowing me to be a part of this. I just want to make clear, I'm speaking in my personal capacity here, not an organizational one. And as is always the case with events like this, a lot of the points that I think I'd like to raise have been touched on or alluded to in part. Which is good, because it means that at least there's a synergy to some of the messages that's being said. Look, I just want to touch on three basic points, if I could. One is setting the findings of the report into the wider global health context of non-communicable diseases, looking at the issue of equality and who has access, and then finally coming to the point around the importance of investing in primary health care, primary level health care. The health conditions captured in this report are not an isolated issue. They're part of a cluster of health conditions that we all know that are called non-communicable diseases. What's probably less known is that these are the world's largest killers. They account for over 70% of deaths worldwide, cardiovascular disease being one of the biggest killers of all amongst them. So this isn't just a European issue that we're talking about here. This is very much global. And just to emphasize that point, that 75% of these NCD deaths actually are occurring in low and middle income countries. But the cruel truth, though, is that the fact that although the vast majority of NCDs occur in later life, the link between living with these chronic illnesses and often living with multiple chronic illnesses in aging is often downplayed. And this comes through in part in one of the findings of the report, which is the lack of data that's there on structural heart disease. But this is just emblematic of a systematic problem in the way that NCDs are reported. The UN's global indicator for tackling NCDs, for example, so-called premature mortality, stops being measured at the age of 70. Now, this sends a really clear signal to policymakers and clinicians and practitioners that improving health in later life is just not important. And I think we're seeing the end result of that through the findings of this report. The good news is that there is a move to try to rebalance this. And although that global indicator on NCDs, ironically, was set by the WHO, another part of the WHO has also recognized and done a huge amount of work on what is healthy aging. And it's reframed our understanding about this to focus on maintaining functionality, so optimizing people's capacities and abilities throughout their life course. And this is really helpful for us. And I think it really sets in part what the report is pointing to into a context that this is, yes, about actually very specific medical interventions, but we have to look at what does this do, and setting this into a broader context of broader public health framework for healthy aging. And Sylvia and Perel Levin has been part of a team that's provided a set of tools that can help provide some guidance on this. The report made the link as well with COVID-19 and the impact of comorbidities. I'm not going to dwell on that, but it does reinforce the importance of prevention, of detection, and of treatment. And that's something that I think we should all take away from this. The second point is around equality and who has access. Look, Sylvia, and not just Sylvia, but Judith also pointed to this. We must go back to the basic principle when we're having this discussion of the right to health that is enshrined as a human right for all people. Interesting, it's also been captured by another global policy and framework called the Sustainable Development Goals, which says to ensure healthy lives and promote well-being for all at all ages. And these are things that all governments, no matter where they are in the world, have signed up to. And it's our duty as citizens to hold them to account for delivering on this and not to let them forget those crucial words for all at all ages. The WHO is clear in its own guidance that older people should have equal opportunity to access the determinants of healthy aging, regardless of their social or economic status, regardless of the place of birth or residence or other social factors. And that brings me to 2 points that I think are really missing in terms of the discussion we've had so far. One is gender. And what is the impact of women on with structural heart disease, both as people who are potentially could be victim to this, but also the impact of women for looking as carers, as looking after others in society. Just on the point that on the more medical side of things, it's been well established that women across the EU and globally are living longer than men, but it's also been very well established that healthy life expectancy in later life is less than for men. So they're living longer, women are living longer, but with greater health problems and disability. And unless we address this head on and look at structural heart disease, with also that gender difference in mind, we're going to miss a huge set of needs. And this isn't just me saying this. The Lancet Commission on Women and Cardiovascular Disease, they just issued a report a couple of weeks ago that looks at the Global Burden of Disease Index. And one of the things that it has said quite clearly is that cardiovascular disease in women remains understudied, underrecognized, underdiagnosed, and undertreated globally. Interestingly enough, another one of the findings is that in countries with low socio-demographic indexes that have demographic indexes, less economic status, have a whole range of factors that figure into that. The highest rates of cardiovascular disease mortality are shifting from men to women. So there is very much an issue within this about equality and the impact that inequality has, the socioeconomic factors that are affecting access to health services. COVID-19 has really brought this to the fore, and we've seen the impact that access to health services, but also the greater vulnerability to diseases like COVID is in those populations that are less that are more unequal in society. And finally, the last point I want to make is around this issue of primary health care. And we are talking, yes, about how to intervene with a tertiary level surgical procedure. But as we've heard, actually, this only works if you actually are able to have the diagnosis early on, if awareness is taking place. And this comes back to the point that Sylvia was raising, that ageism is intimately linked with health-seeking behaviors and with prevention and treatment. And it's not just the ageism of the health practitioners, but it's the internalized ageism. It's the ability of a person to think that actually what is going on in their own bodies is actually worth treating, is something worth paying attention to. And the report clearly identified that there is a tendency to dismiss symptoms on the basis of a person's age. But this point that there is a lack of awareness amongst medical professionals is really crucial. And so there has to be a comprehensive package of training for healthcare professionals in delivering healthcare at a primary level. And this is, it's really striking, the fact that we desperately need this so much still in a European context. You can just imagine how desperate that need is in a global context and also in lower middle income countries. And my final point is that one of the things I think is really going to help improve these things is, and to help to change attitudes, is that we've got to, I think, find and really promote positive examples of what improved health in later life means in practice for people. And Paolo's last example, the story he told, I think is a great illustration of that. We must reframe people's perceptions of aging and older people's health in society from a deficit model to one that is an investment in society. Thanks.
Thank you very much, Ken. We now move into the session where question and answers that have been posted during the session are put to the panelists. Well, there are 25 questions and we have about 15 minutes to go. So I'm going to try and distill some of the themes that have come through the questions. I'm going to start with Ken and ask him to answer the question, which I'll also put to Sylvia, which is, clearly sort of age-related discrimination is an issue, and I think everyone in society recognizes that we treat elderly people different from those in younger ages. If there was one policy intervention that parliamentarians either in the EU or in the UK government could undertake to help address this, what would that one thing? I know there are multiple things that could be done, but what would be the single highest priority that you think? And I'll ask Sylvia the same question in a second.
Well, I'm going to steal Sylvia's thunder, because we would say the same thing on this. And it's not an easy answer, it's not an easy solution, but it's absolutely critical, which is that what we really need is this global set of standards that completely reframes our understanding of older age, so this Convention on the Rights of Older Persons. And the proof of that this is not only possible, but that it delivers results is when we think about the huge changes that have taken place with attitudes and legislation and policies and programs for people with disabilities. And this came about because there was a process that raised awareness that we must treat people with disabilities as human beings, and we must accommodate as society their human rights. We are not saying that older people are, all older people are people living with disabilities. No, but we're saying that there's a model, an example here that must be used by society. And it's through that change of attitude, through that reframing of perceptions, that we're going to see a requirement for healthcare practices to be asking those basic questions. Why aren't you using a stethoscope? Why aren't you asking every person? Why aren't we measuring actually the health outcomes of people in later life equally to those in earlier ages? So that's my answer.
Thank you, Ken. Sylvia, would you like to add to that?
Thank you. Of course, I agree with Ken and on the global need for the convention. But I also think that on the national level, parliamentarians have a duty to, as I said, forbid age-based discrimination, to make it illegal on all grounds. And as of today, age-based discrimination is enshrined in many laws, and that should be stricken off. And I think that is a duty of parliamentarians, and also to watch our language. I mentioned before, and I mentioned it now, let's stop talking about the elderly. We are older persons. We are not all frail. Stop putting older persons all in one category. Let's stop using phrases like "for as long as possible." That already assumes that at some point our autonomy will stop. The default has to be autonomy of independence and independence, and we deserve and we should be entitled to equality treatment before the law like everybody else. Thank you.
Thank you, Sylvia. Another theme that has come up, and this question goes to Baroness Jolly. I've got a different question for Paolo. So Baroness Jolly, one of the themes that's coming up in the Q&As is that we sort of know that cardiovascular disease, and specifically structural heart disease, is a major killer and a cause of considerable morbidity. What can we do to support parliamentarians in helping to raise the profile of cardiovascular conditions?
I think that probably one of the most useful things is if we were to put down questions to ministers and put down debate titles so that we can have an hour or 2 hours discussing a topic. And then what inevitably happens is that experts pick up that these debates are happening and they send us accurate, up-to-date briefings. And the other thing I want to just get in quickly is this issue of what will it take to elevate the prioritization of cardiovascular disease and SHD. And I think majority of the policymakers, the politicians who are making the policies, are under 45, and their parents are not of an age where they are yet particularly hitting this sort of buffer that we've been discussing. And they certainly aren't there yet. And majority of the senior politicians involved in health are men and are very gung-ho, and they're always right. And sometimes that isn't easy. But I think that the issue of raising the priority of SHD, which Liam Hansen has mentioned, it isn't on anyone's radar in the Department of Health, so they don't talk about it and they don't do anything about it. So it's a case of trying to assemble enough voices to put a really, really big shout out. There is institutional ageism within the NHS. And that's really, really difficult. But again, all the policymakers are quite a lot younger. Special advisors who advise on policy are probably no older than 30, 35. So you don't have anybody with an old voice in policymaking in the UK. And that's a shame.
And in terms of the parliamentary debates, which you've referred to, and I would imagine it's the same in the EU and other national governments, which is the best way to influence getting this subject debated? Is it through patient advocacy groups? Is it better from specialist societies? Where would the response be most positive?
All of the above, really. If they could act together on a particular issue, structural heart defects come to mind, and bombard. It doesn't take very long for an organisation, a lobbying organisation, to work out who are the people in both the House of Lords and the House of Commons who speak on these issues when they're raised, and just ask them to put a debate down and then send them all the information that they need in order to put together a well-structured debate on the topic, so that you can then force a minister to stand at the dispatch box and give you answers. And if you don't get answers, you ask why not, and you just keep pushing at it. And that's what the advantage of the House of Lords is. We don't have to worry about getting ourselves re-elected, which members of the House of Commons do. So we're there forever, and there is a huge body of experience and expertise on health-related issues in the House of Lords, who is used all the time on this sort of issue. And I've spoken to Ken in this context as well. So people know about it, and if a debate goes down about heart-related issues, all of the bodies who are concerned about that will send us a briefing, which is really, really helpful. But it means that is an opportunity for them to get their message out. And if something is really topical, they will drop me a line and say, can I put a question down about this? And I can turn that round inside half an hour if it's something I think worth doing.
Thank you very much. Excellent advice, which I'm sure will be acted upon, so you can expect a mailbox.
That's what I'm for.
The question for you, Paolo,
yes.
Which is looking at it from a European perspective. What are the sort of pan-European initiatives that you think are most likely to make a difference? And perhaps also just touching on the question of data, which was raised in the report, and you obviously have quite good data in Italy. Perhaps you'd like to give us a European perspective.
Yes. Now, first of all, all of us know that the duration of the mandate of politicians is too short compared to the, let's say, natural history of chronic diseases like SHDs. This means that politicians should think ahead much well beyond their mandate to build very important innovative policies and useful policies. The other point, in my opinion, is that we need to have in the society, as well as according to politicians, we need to have a sort of intergenerational alliance, which was, as has been probably a little bit mentioned at the very early part of this webinar, which means that I mean, if you are a teenager, you should look at your grandparents, their health or not, and see what happens. And think your life trajectory in that way, which means prevention at any age. So the concept of age is important, but not so much in terms of prevention and identification of problems. The other point is ageism. I'm totally agree with Ken. Ageism is not only a discrimination versus to age, but also to women, to gender discrimination. So women suffer a double discrimination, if you want, in terms of, for example, cardiovascular diseases. So I think that we really need to implement some important, let's say, actions at the central organism. One possibility is to think about the fact that some of the, let's say environmental factors, let's say promoting, let's say, cancer, are the same that promote cardiovascular disease somehow. So we may also even build a, maybe this is too much visionary, but a sort of coalition according to what is the so-called exposome, all the factors we are exposed to, and promote cardiovascular, chronic diseases. And sometimes people suffer by the combination of cancer and cardiovascular disease. So, you know, we are not just, you know, pieces together, but we are we are persons with several psychological and physical problems. So this is another possibility. The other point is data issue. Okay, now we are in the era of big data, and you know that big data, if they are not well collected, can generate big noise. So it is very important to have a standardized way of collecting data in order to compare them. So it's important to put together this information. Also because, I mean, each country can be somehow separated, but we are actually all of us on the same boat, if you want. So there is no point to have different strategies. Okay, thanks.
Thank you very much, Paolo. And my apologies to those who've posted more specific questions on the Q&A. It's not been possible to direct all of those, but we'll try to respond to them later. Just one last question before I start to wrap up, because we need to finish at 2:30 UK time. I thought a question to Ken just about issues related to COVID. I think as healthcare professionals, we've heard a lot about and seen a lot of reduction in people approaching hospitals and being diagnosed. I wondered if that's something you'd like to comment on, how the pandemic has affected the situation.
Well, absolutely. I mean, look, there's the obvious pressures, of course, that the healthcare systems have been under, and the fact that people simply do not have access to the ordinary routine procedures that we would have expected under normal circumstances. But then, of course, that you add to this the discussion we've just been having, which is the prioritization that happens, even if it's implicitly, not only as what an individual is experiencing, you know, should I put myself forward? Is it possible? You know, as well as the way that they're received. You know, time and again, we hear the refrain, well, of course, you know, you're feeling this way, you're just getting older, you know. What we know from this report and from our experience is that, you know, this isn't sufficient. And what is really galling, actually, is the fact that we are, those attitudes, those approaches, quite explicitly puts a value on a person's life and says that actually we are going to say that your life, for whatever it is, you know, for however many, we have absolutely no idea how much more life you have left, nor what you're going to do with that life. And, you know, we shouldn't even be utilitarian about this, but every person's life should be treated the same. And it comes back to that deficit model. And unfortunately, even though the positive thing about COVID has been that we've seen, you know, a huge response by many governments that actually have quite actively sought to protect the health rights of older people and through the vaccination program. And that's been hugely positive. But we've also seen in countries like Bulgaria, for example, quite the opposite, where there's been a very explicit decision made to say that if you no longer have perceived economic value, then your life isn't worth saving. So we still have a long way to go.
Thank you very much, Ken, and a very good point to begin to wrap up on. Before I make some closing remarks, I just ask Aaron, is there anything else that you wanted to highlight before we draw this to a close?
Thank you. Yes, just one thing I thought I'd leave the discussion on is just to say that, you know, I think tackling SHD for politicians, for government, should be seen as quite a quick win for them, particularly when we're comparing that in terms of other conditions which are heavily linked to lifestyle, and which often require sort of a multi-sectoral approach to addressing them. Of course, there are these underlying issues of ageism that will take much more time to address, but I think sort of demonstrating that case clearly to politicians is something that we really need to be focusing on, and it really needs to be communicated that actually, even through some simple steps like getting individuals having their heart checked, can have a huge impact on the numbers. And then alongside that, we can work on these these much more difficult issues that we're facing.
And I think another point to take away is that making these trying to encourage these changes is best done collaboratively and jointly, because the more the message that gets across as a single message, the easier it is for changes to be made. So thank you to all of our speakers and everyone who joined us for our launch today. Thanks also to Edwards Life Sciences for supporting the project. The report is available from the ILC website, along with the slides and the recording of today's launch. Join the ILC on Thursday, the 10th of June, for the launch of their upcoming Longevity of Sporting Legends, which investigates the longevity of sporting legends who've reached the pinnacle of their profession. And ILC are currently also running an international competition called Work for Tomorrow to identify and award the most promising innovations responding to an aging workforce. Applications run until the 1st of September 2021, and if you or someone you know is interested in entering the competition, visit the ILC website for more information. To find out more about the different competition categories, join ILC's challenging webinar on the 24th of June, which will be delving into the challenges and opportunities that arise from an aging workforce. Early bird tickets are now available for ILC's annual Future of Aging conference, which will be held on Thursday, the 2nd of December. This year's conference, the ILC will focus on recognizing the increasingly diverse characteristics, experiences, and life trajectories of older people of today and tomorrow. And for other news on ILC's latest webinars and to stay up to date with all ILC news, please visit their website at ilcuk.org.uk to join the mailing list and follow the ILC on Facebook and Twitter at ILCUK. So with that, we hope that you attend another webinar or event in the near future. Thank you very much for attending today, and do download the report and read it. It makes good reading. So thank you very much for attending, and thanks to all our panelists.
Thank you very much.
Thank you.
Thank you, everyone.
Bye. Thank you.
Too short. We have so many things to say. We may even have a second webinar on this topic.
Indeed.
Very nice speaking with you all.